Good evening. A warm welcome to all of you. Today's webinar on what the GP should know about thyroid disease is organized by the NCD Committee of the College of General Practitioners of Sri Lanka. This evening, our speaker is Dr. Sonali Gunathilaka, consultant endocrinologist at District General Hospital, Nuwara. She is a popular physician and a much sought after lecturer in endocrinology. Over to you, Sonali. Sonali, over to you. You can take over.
Hi, good evening. Can somebody confirm me whether you can hear me or not?
Can hear.
I can't, of course, hear anything. Can somebody just say whether you can hear me?
Can hear.
Yes, we can hear you.
Can hear.
Go ahead. Please proceed.
Thank you.
Oops, I of course can't hear anything. Let me just. Okay, so y'all can hear me. That's great. Okay, backwards I can't hear anything. Anyway, so I think I'm the first one to start now. I don't know whether you all had anything going on. Okay, right. So let me just shut down this. Okay. Good evening. It's a busy time and lazy time, 9 o'clock. But thank you very much for joining with me. I'm Dr. Gunathilaka. I'm one of the endocrinologists currently remaining in Sri Lanka for the moment. So I work in DGH Nuwara, one of the most remote places. But even there, we try to give our best service and then manage patients as much as possible with the limited resources that we have. And even there, with the GPs, I interact quite frequently, and I've done a couple of lectures with regard to diabetes and thyroid, and the contents of this lecture have been found to be quite useful for the GPs in Nuwara. So I hope you all also would be benefited. But if you have any queries, please do not hesitate to contact me, or just write something on chat or shout out in between the lecture. Okay, let's proceed. And okay, if we take the thyroid problems, I know you all are scattered around the country. And then if you see the prevalence in Sri Lanka and epidemiology of goiters, there's a belt. Let me just put out this laser pointer. Okay. Now, we don't have Northern Province data, but if you see the dark blue color belt, the Central Province, part of Northwest, and then like Sabaragamuwa, and also going in towards Uva Province, there's a belt, and there are some pockets of goiters with high prevalence of goiters. In Nuwara, I see quite a number of goiters. Surprisingly, I don't know why it is, but maybe iodine or something, but there are different pockets in Sri Lanka with regard to goiters. And thyroid functions, if you take majority of our patients are, this is Indian data by the way, but we behave quite similar to Indians. A majority will have thyroid functions normal in the biochemistry, but of the disease population, of the 20% who have thyroid anomalies in their blood reports, majority will be subclinical hypothyroid, 9%, and followed by hypothyroidism, and then you get the other varieties like subclinical hyper and genuine hyperthyroidism and sort of. So it's important in your practice to know about subclinical disease as well as genuine overt hyper and hypothyroidism. Same way, it is important to know about the goiters because it's prevalent in Sri Lanka. So outline of my lecture would be, I'll just roughly go through thyroid hormone regulation and then moving on to real management of hypothyroidism, hyperthyroidism, and subclinical thyroid disease. A little bit of a word on thyroid disease in pregnancy because it is a specialized management protocol, but what we need to know as GPs and management of nodular goiters. If I take the physiological effects of thyroid hormone, well, thyroid hormones are kind of metabolic hormones. So they increase and maintain the metabolism of our body involving the major organ systems, right? So if I take metabolism alone, it increases it is responsible for glucose and lipid metabolism as well as proteins, proteinolysis and protein synthesis. It's a balance of these thyroid hormones that carry out in our body. So if somebody has excess or reduction in thyroid hormone, all these glucose, protein, and lipid metabolism changes. High thyroid hormones, metabolism increases. Low thyroid hormone, metabolism reduces and slows down the body metabolism. Apart from metabolism, it has two main effects on cardiovascular system and sympathetic nervous system. So cardiovascular system is stimulated and with chronotropic and inotropic actions of thyroxine on the heart as well as blood vessels, and sympathetic nervous system. Thyroxine hormone increases the synthesis of beta-adrenergic receptors. So when you have more thyroxine, more beta-adrenergic receptors will be there to act through catecholamines. So you get more of sympathetic nervous system effects when you have more thyroxine hormone levels. And if I just brief you out about physiology, this is important when you start interpreting thyroid hormone profiles. It's okay when you get a straightforward report, but when you get a funny report or when you get a report which you need to twist your brain, this process is important to know. So hypothalamus secretes a releasing hormone called TRH, which we don't use much in clinical practice, but TRH stimulates anterior pituitary to produce TSH, that is thyroid stimulating hormone. This hormone is stimulatory to our thyroid gland, which in turn produces a lot of T4 levels, T4 hormones, and a little bit of T3 hormones. This T4 is not the active. T3 is the active form. So T4 gets converted in the peripheries into T3. T4 converts to T3, and then T3 acts on the tissues itself. When there's enough T4, T3, then pituitary as well as the hypothalamus detects the level of T4 and T3 in the body and then regulates its production. So when you have a lot of T4, T3, pituitary detects it and then reduces the messages sent from the pituitary to the thyroid gland to produce T4, T3. So if there are excess T4, T3, the TSH message will be reduced. In case of reduced amount of T4 and T3 produced by the thyroid gland, then pituitary detects, okay, there is not enough thyroxine hormone in the body, so I should send more and more messages to the thyroid, asking the thyroid to produce more and more thyroxine hormones. Therefore, low T4 and T3 induces pituitary to produce more and more TSH. So TSH will be high and T4, T3 will be low in that case. So the same thing I told, underactive thyroid, where there's not enough thyroxine in the body, causes low T4 levels, and then in turn, as a feedback mechanism, pituitary detects and sends a lot of TSH to stimulate the thyroid gland. Whereas if the thyroid gland is producing too much of thyroxine, then you will detect a lot of high level of T4, T3 in the blood, the system, and then as a result, pituitary detects there's too much of thyroxine, and then it sends less amount of signals to the thyroid gland. So high T4 level classically produces low TSH if all the systems are functioning pretty well. Okay, now let's move on to different clinical scenarios with regard to thyroid. Now, scenario 1, this patient comes to you, 32-year-old male, weight gain, lethargy, and constipation for 8 months. So you know what's going on here in this patient. And you suspect weight gain, lethargy, constipation, okay, a little bit of hypothyroid symptoms, and neck examination, it's normal. And you order TSH levels, that becomes as 75, more than 75. So it's beyond, it's very high, which means pituitary is secreting a lot of messages for the thyroid to produce more and more thyroxine. So, okay, TSH is high, which means that obviously T4 should be low. Low T4 stimulates pituitary to cause high TSH production. So in this way, although TSH is high, T4 still remains low because the thyroid gland is not functioning. However much there are messages, gland is not functioning, therefore the T4 is low. In that case, the problem is in the thyroid gland, therefore we call it primary, and problem is lack of thyroxine hormone produced by the thyroid gland, therefore we call it primary hypothyroidism. Okay, we usually classically don't do T4 levels in primary hypothyroidism. If the TSH is more than 75, it is very obvious. But having done T4 levels, you will see that T4 levels will be quite low. Now, why do I say it's only TSH, not T4? Now, if you look at this graph about severity of hypothyroidism and how the TSH T4 behaves, you can see in normal people, TSH is normal. And then when there is hypothyroidism at the earliest state, pituitary detects this and then increases the TSH production. This mild at the earlier stage, you may appreciate that T4 levels, by increasing the TSH, T4 levels can remain normal, even though there is some degree of hypothyroidism. So if you do the test at this time, your T4 levels would be normal, but TSH will indicate that there is some degree of hypothyroidism. Same goes with T3, so T4, T3. You may appreciate that T4, T3 reduction takes place much, much later than TSH. So if you are to detect hypothyroidism early, it should be TSH, and TSH is a very sensitive marker of hypothyroidism. So it rises first and abruptly, and T4, after that T3, decline occurs slowly and later than TSH. So we encourage people to do TSH as a screening test. Okay, now this patient has primary hypothyroidism. What are the symptoms? Can we rely on this? Like I said, thyroxine hormone is a metabolic hormone. So when there's less amount of thyroxine, you get loads of effects due to metabolic effects. That is, low thyroxine causes low metabolism. So the metabolism and all the body system slows down. Therefore, you can predict the symptoms, what you get in this body, because everything slows down. Okay, so because of the slowing down effect, Patient can become hypothermic. Patient feels a lot of coldness, cold intolerance, and heart rate becomes very low. And then gut becomes very slow, therefore constipation. And then dry skin, the skin metabolism does not happen properly, so you get dry skin. And mentally, CNS slows down, therefore you get lethargy, sleepiness, and those of many other symptoms. Females do get menstrual disturbances, whether it's hyper or hypothyroidism. They can get any kind of menstrual disturbances. And as the metabolism goes down, fat metabolism also slows down, and therefore patient gains weight. And then, yeah, I think I told almost all the symptoms. There are some subtle ones as well, but none of these symptoms are very specific. Now, some people say, I feel very sleepy, so it must be thyroid, and TSH is just 5 or 6. It's not thyroid. So for these patients to get this kind of symptoms, TSH should be significantly higher, like 20 or above. If it is less than that, it's not purely due to hypothyroidism. You have to look for other causes as well, where patients can get, but if none of these symptoms of hyperthyroidism are specific, please do remember that many other diseases can mimic hypothyroidism. So like anemia, TB, some other SLE like connective tissue disorders, and even when the patients are sleepy, they just think it's due to thyroid. No, it is not. If the TSH is normal, it's not due to thyroid. Okay. Now, we know that there is primary hypothyroidism. What causes this hypothyroidism? Patients come and ask, why? Why do I have lack of thyroxine hormones? So it could be many reasons. Commonest would be autoimmune hypothyroidism. And in these patients, anti-TPO antibodies will be positive. It could be following surgery, radiotherapy, or drugs like lithium amiodarone, or some parts of the country maybe iodine deficiency, but I doubt this, because now we have fortified salt with iodine, and some are congenital and some post-thyroiditis. But commonest would be autoimmune hypothyroidism. Okay, now, yes, now these are with consent. I'm showing these. This is an extreme case of hypothyroidism. You can see the rough, dry skin and rough pores phases popped up because of the poor lipid metabolism. And then this patient presented with seizures. And he was drowsy, had bradycardia and hypothermia, and found to have low sodium as well. In severe hypothyroidism, we may expect low sodium, and there was an infection precipitating this. Actually, TSH was more than 75, and this patient presented with myxedema coma status. It's not comatose, but drowsy. This patient, walking, talking patient, again, you can appreciate the coarse features in the face, and then puffy face, dry skin, and he actually presented with not feeling well, muscle aches and pains, and found to have heart rate of 60 with generalized muscle tenderness, and CPK was very high. So hypothyroidism can cause raised CPK as well as low sodium, and TSH was elevated. Now, you know the typical symptoms of hypothyroidism, but there are some atypical symptoms like low sodium, raised cholesterol, high prolactin levels, and raised creatinine kinase. These could trigger you to look for TSH and hypothyroidism, because they are atypical presentations. Okay, now you have a patient, you diagnose hypothyroidism. How do you treat? What is the treatment, how long, and how to monitor? Now, it's important for these patients to know that whether their thyroid is overactive or underactive. Now, when they come to me with a TSH of, let's say, 30, they say, Madam, thyroxine ready, right? It's good if they have the report, but if they don't have the report, then I'm wondering whether thyroxine ready. Is it hyperthyroidism, or is it just TSH varicommeter? They're just telling thyroxine ready. So it's important to educate the patients, because when they go without a prescription, we need to know what exactly is that. And sometimes patients don't know the drug even. So it's important to know, tell them your thyroid is working too much or working less, because that message is important. Now, treatment treatment. Now, when their thyroid is not functioning, it's lifelong. So you have to tell the patient it's lifelong treatment. Otherwise, they will stop. When you write the prescription as thyroxine 6 months, then they stop thyroxine after 6 months and don't come to you. Tell it's lifelong treatment. This drug is needed for your normal metabolism and for your brain and heart to work properly. And it's not actually a drug. It is almost a hormone where it is similar to the hormone that you have in your body. Therefore, no side effects. So don't be afraid, take the treatment. And how do you treat? Yeah, well, treatment is thyroxine. So we give T4 in the pill form. And how do you decide the dose? For person A, person B, and person C, it's not always 25 mites or 50 mites or 100 mites. It depends on the patient's body weight. How do you calculate it? Usually the dose is 1.6 micrograms per kg per day. So if I just take a 60-year-old gentleman, 60 into 1.6. So somewhere around 100 micrograms a day would be the ideal dose. This depends on their compliance and sort of other drugs that they say take, but this is a rough guide. So you can assume what the patient is taking and then decide on the dose. For young people, you can straight away start with 100 or what their desired dose. You don't have to start with 25 and increase to 50. Start with 100 or 150 if they don't have any issues, if their weight adjusted thyroxine dose is that. When you prescribe it, it's important to tell the patients proper instructions. You have to take early morning, empty stomach, and avoid any drug or food, especially food, for at least 30 to 45 minutes. Best would be 1 hour, no drugs or no no food or no milk or anything, just water within that 1 hour of ingestion. But if somebody can't make it for 1 hour, minimum would be 30 minutes. But well, in between value, 45 minutes is a reasonable value. Now, some people keep the alarm at 5 o'clock and then drink thyroxine and wake up at around 7. You don't have to drink thyroxine early in the morning. So if somebody wakes up at 6, that's fine. And if somebody wakes up at 10, that's fine. Again, even at 10 a.m. But make sure they take the thyroxine and wait for at least 30 minutes to 45 minutes or maximum 10 minutes 1 hour would be the best before taking any milk or tea or food items, right? Okay, so and then drugs. When I talk about drugs, especially post-thyroidectomy, make sure if the patients are on calcium or iron supplements, it has to be at least 4 hours apart from thyroxine. Not other drugs, but especially calcium and iron supplements. Make sure they are given at night or at least 4 hours apart from thyroxine. Okay, how do you monitor? Now, you prescribe the dose when you diagnose hypothyroidism, and then what to do? Dose titration should be done, like if you start initially, don't do TSH every 2 weekly or 4 weekly. It should be done at least 6 to 8 weeks apart, because it takes 6 to 8 weeks for the TSH to stabilize, and you monitor only with TSH. Like I said, don't do T4, T3 in hypothyroidism. Just do TSH 6 to 8 weekly, and then once the TSH stabilizes, you know that TSH has become normal for a couple of times, and then you don't have to see these patients and monitor every 3 monthly. It should be annually, unless the patient has disease or symptoms developing, then you can do early, but otherwise stable patient, stable dose, it's annual monitoring. If you want to increase or decrease the dose once the patient is on thyroxine, you may do it as 25 to 50 microgram increment or decrement. That is your choice. But this is not the rule for everybody. For special situations like in elderly and patients with heart disease, this category are more prone to develop MIs and arrhythmias, you should start very slow and go very low dose and go very slow. So in, let's say, 75-year-old gentleman coming with a TSH of 50, I usually start with 25 micrograms because he's elderly and can get a heart attack if I get if I give him, or arrhythmia if I give him 100 micrograms of thyroxine. So I start with 25 and I don't repeat TSH in 6 weeks or 8 weeks. I usually wait for about 3 months and then repeat and then do very slow increments of 25 microgram at a time. You go very slow and low dose in elderly and patients with heart disease. Okay, I'll just quickly rush through, otherwise I don't think I can cover up much of the topic. Now this patient, we have started the same patient, TSH more than 75. I have started thyroxine 75 micrograms, and in 6 weeks time, TSH is 15, whereas it should be normalized. Now what's wrong with this? I expect it to be normal with 75, but it has not. But you may appreciate T4 is normal. So that's why we don't encourage you to do T4 in follow-up, because this deceives you. You think, okay, T4 normal, but TSH is high. So this is a discrepancy. No, it is not, because T4 is very short lasting and it does not indicate the adequacy of thyroxine hormone level. Go with TSH. It could be poor compliance or inadequate T4 dose. You check the compliance with patients always deny, but you better to be very strict and check it. But you then see whether the dose is adequate. It's 60 kg and 1.6 is somewhere around 75, 100. I'm giving 75. So whereas here, I'm not giving enough thyroxine to this gentleman. Therefore, if I give 100, then in 3 months, you can see the TSH has become normal. So make sure when you get these kind of reports, please do check the basics. Here, sometimes if the patient is non-compliant also, this report can be there. What has happened is patient has not taken thyroxine for some time or defaulted. And then because the patient is coming to you, has taken thyroxine for the last 1 or 2 weeks. Then T4 will be normal, but TSH takes time. This indicates the previous non-compliance if the dose is correct. Okay, now we have seen a lot of people doing TPO antibodies in hypothyroidism. So TSH is more than 75, they do ask the patient to do TPO antibodies. TPO antibodies indicate the etiology is Hashimoto's. It is associated with Hashimoto's disease, but it has no place in management in overt hypothyroidism. It has a place in management in subclinical disease only among pregnant or subfertile ladies, unless you see a patient in that category. I don't see a major value in doing TPO antibodies in routine hypothyroidism. It's just cost. And what about a place for ultrasound scan in hypothyroidism? We see a lot of patients undergoing scans in hypothyroidism. I rarely do it. It is not indicated routinely in hypothyroidism unless you feel a nodule or you suspect something, or if there's a strong family history of malignancy, you do it. Otherwise, routinely, you do not have to do it because you don't get any additional information. Okay, I'll just quickly rush through this about this patient. Now, this patient is 70 kgs, 32 years, primary hypothyroidism on thyroxine 200. You may see even 300, 400. I saw a patient very recently with 500 micrograms a day. And TSH is never normal. Why is this? So again, we check the compliance. Patient says normal, no drug interference, no food interference. And then I check the dose. Well, his usual dose should be 112. If it is 1.8, it has to be 125 maximum. But the patient is on 200 micrograms. So this is kind of a resistance. It's almost always due to compliance. But here we call it refractory hypothyroidism. TSH is persistently elevated above the reference range, and despite being on thyroxine more than 2.5 mics per kg per day. In that case, we call it refractory hypothyroidism, and the causes are commonly it's compliance. If you check, it will be compliance. Very rarely, sometimes dose inadequacy or storage issues or thyroxine brand. Now, storage issues, if the thyroxine is kept in near the leaper or like at a higher temperature or on top of the fridge, well, it may cause problems in certain brands. Therefore, make sure the thyroxine is kept in a cool place, reasonably cool place in a drawer or somewhere, and not exposed to direct sunlight. It's not proven, but sometimes some brands are very sensitive. And then very rarely the endocrinologist come here in evaluating any assay interference and malabsorption in these situations. If the compliance and other drug inadequacy and other storage issues are sorted by the GPs, then it's time for you to refer to us. And I believe that simple hypothyroidism should be managed at GP level, not endocrinologist or VP level, because it's routine practice. And if there are problems only, should be referred to us. We sort it out and we refer back. So we do a lot of tests like thyroxine absorption test and supervised weekly administration and trial of other forms of thyroxine, especially in other countries. We do this in these kind of refractory hypothyroidism. Okay, thyroxine absorption test, I would not go into detail. We give a large dose of thyroxine and then check the T4 absorption. Now you see there's no increment even after a very large dose. So this is some kind of a malabsorption. Whereas here in this patient, you see starting with 2.1, it has gone up to 16 and 19. So there's a good absorption following a high dose. Then we declare there's no malabsorption. It is just compliance. And there are other things that we do, so I would not go into that detail. There are some questions. I will try to answer questions in this section. So, okay. T4, are these all T4 same in the market? I trust we're having good results with these different brands. Yeah, now brand-wise, there's a problem. Some brands are said to be good, some are not very popular. How I tell this is by experience. When the patient changes from one brand to the other, although the compliance is normal, the dose is same, sometimes we see a change in TSH. So we advise them to stick to the same brand if possible. If brands are changed, then you need to check with the TSH and then sort it out. I can't directly comment on which brand is better, which brand is not, but even in the hospital, we see quite a good result with TSH. We don't find any problem in hospital brands for the moment, right? They do change. Now, what are the drugs reduce absorption? Omeprazole. Well, drugs in the sense, omeprazole has some effect because some level of gastric acidity is important for thyroxine absorption. But most of the drug interferences are with calcium and iron supplements. Dose calculation, don't we need to consider the severity or deficiency or symptoms other than the body weight? Well, I was talking about overt hypothyroidism. So in overt hypothyroidism, where the TSH is usually more than 20, usually the dose is calculated with weight. Now, obviously, I agree in subclinical disease where the TSH is marginally raised, we don't go with the body weight. Now, my topic, if you can see, it is hypothyroidism, initially the overt one. I'm not talking about the subclinical disease, which I will talk later. So this is overt hypothyroidism where the TSH is grossly elevated, right? Okay. Is there a special advice to follow before collecting blood for TSH? No, TSH blood can be done at any time. Fasting, non-fasting, it doesn't matter. Taking thyroxine tablets or not, it doesn't matter. So usually we ask the patient to take thyroxine and then go to the lab in the morning or evening and then do it. There's no specific instructions for TSH assay. But T4, of course, if you are doing, at least try to do T4 measurement after 4 hours of thyroxine injection or before thyroxine, I would say, because it can change. Like I said, it absorbs and goes, the levels become high rather than stabilizing. So after taking thyroxine, 4 hours after or before thyroxine dose, you have to do T4 levels, but TSH does not have that kind of a thing. What are the drugs interact with thyroxine, which we can't prescribe when taken? Like I said, it's mainly, there are no drugs which you can't prescribe. It's just space it out, right? Especially calcium and iron tablets. If marginally elevated TSH, are we going to start thyroxine? That is subclinical disease. I will try to cover if I have time, right? Okay, let's go for hyperthyroidism quickly because this is also important. This is how I manage. Now, scenario 3, this is 30-year-old female feeling unwell with palpitations, sweating, loss of weight for 4 weeks. TSH is very suppressed. Now, Why TSH is suppressed? Because pituitary is not giving enough messages. Why is that? One reason could be the pituitary detects loads of T4 and T3 in the system. Therefore, thyroid gland is producing loads of thyroxine, and then it is detected by pituitary. So pituitary does not produce much of signals to thyroid gland. Therefore, TSH is low and T4 is high. Here, I stress you need to do a T4 level to confirm this hyperthyroid state. Please do not treat hyperthyroidism only with TSH values, because you are going to go wrong. That's where most of our people go wrong, because you don't give a proper treatment or adequate dose, right? Okay. Now, right. Why have I used urine HCG negative? Now, sometimes we'll discuss later if we have time. Urine HCG, the HCG acts similar to TSH. So, if a patient is pregnant, HCG is very high, and that cross-reacts with TSH, and thyroid gland thinks, okay, this HCG is TSH, and I am supposed to produce more and more thyroxine. So it's important in young females, if you detect a low TSH levels, check for urine HCG and make sure the patient is not pregnant, right? Okay. Now, what the problem here is, gland is producing too much of thyroxine, and that's why T4 is high and TSH is low. We call this hyperthyroidism, right? Now, like in hypothyroidism, this is a metabolic hormone. So excess thyroxine hormone causes excess metabolic rate. Therefore, patient will be very much, metabolism is high. Therefore, patient will have significant loss of weight despite increased appetite. And then patient will have heat intolerance. Body is producing too much of heat. And then patient will have cardiovascular symptoms like palpitations, and sometimes heart failure, heart arrhythmias, central nervous autonomic symptoms like tremors and sweating in these patients. And also GI system works quite fast, causing diarrhea or increased bowel movements. And again, muscle weakness and wasting can happen because of the high metabolism. And also patients do get menstrual changes, especially in females. So cardiovascular, keep a watch on atrial fibrillations and heart failures in these patients. So what is the etiology? What is the treatment? Now, etiology of hyperthyroidism is of has four things. Classically, it's Graves' disease, or it could be subacute thyroiditis, or toxic nodule, or multinodular goiter. Now, usually our gland is very diffuse. And then if the gland has, let's start from the corner, multiple nodules, and all these nodules try to produce too much of thyroxine, we call it toxic multinodular goiter. If there's only one nodule, again, that becomes autonomous and starts producing too much of thyroxine, going against the normal feedback mechanisms, again, we call solitary toxic nodule. But if there are no nodules, if the gland is enlarged diffusely, the differential diagnosis could be Graves' disease or subacute thyroiditis. Now, this subacute thyroiditis, what I'm talking is not the scan mentioning thyroiditis. If you do thyroid scans, you see in almost everybody, they mention as thyroiditis. Don't go with that for your clinical judgment, because that is a kind of a scan appearance. It is not the thyroiditis that I'm talking. Now, Graves' disease is autoantibodies, TSH receptor autoantibodies stimulating the thyroid gland to produce too much of thyroxine. What is subacute thyroiditis? It is not the gland producing thyroxine. It is kind of an inflammation or sick gland. Now, this inflamed thyroid gland becomes enlarged, and they are very sick. Therefore, already produced thyroxine within the colloid or within the gland will be released into the system. It's not that the gland is very active. It's just that the already produced stored thyroxine will be released due to leakiness of this thyroid gland. Whereas Graves, the gland is very active and produces too much of thyroxine. Right? The clues are, obviously, if you palpate, you will see multinodular goiter or toxic nodula, or if you do a scan, you can detect that. But in these conditions, the gland will be diffusely enlarged, and there will be some autoimmunity or family history of thyroid disease in Graves' disease. And also sometimes they have some peculiar eye symptoms, which I will talk later. In thyroiditis, you will classically see a severely tender or painful neck, or history of tender, painful neck or upper respiratory tract infection about a couple of weeks back. And they don't even allow us to touch the neck. It's that tender because it's inflammation. So how do you do? What are the investigations? If you do a scan, it's diffusely enlarged goiter in both. But as I said, Graves' disease is very active gland, which needs a lot of vascularity. So vascularity will be high in Graves' disease. If the radiologist has mentioned, vascularity will be low in thyroiditis. You can do TSH receptor antibodies, which is about 12,000, 15,000 rupees. But in thyroiditis, if you do ESR and CRP, they will be markedly elevated. Sometimes it's 50, 30, sometimes even 100 ESR. And if you take, very rarely we do uptake scans because it's not available. Technetium uptake scan, Graves' disease is very active disease, so technetium will be taken diffusely. Whereas thyroiditis, I told you, the gland is not active, it is sick. Therefore, gland will not take up technetium, so you can't see anything in the neck. Toxic nodule, only a nodule will take up, and multinodular goiter, a lot of nodules will take up technetium. So these are the ways that you differentiate these etiologies. Treatment options for hyperthyroidism depends on what the etiology is. So Graves' disease and toxic multinodular goiter, solitary nodular goiter, all three options of medications, radioiodine and thyroidectomy, is like they are all correct. Depends on the region. Now, I know in US, they go for radioactive iodine ablation. And even in New Zealand and Australia, sometimes they go for thyroidectomy straight away. But in UK practice, it's medications initially followed by these other two options. So we go with UK practice usually, unless there are special situations. Therefore, we start with medications. Okay. Now, this patient, same patient, I have done a scan, an examination. It's a diffuse goiter scan, diffuse goiter with increased vascularity, which means the gland is very active, so it is likely to be Graves' disease. Now, Graves' disease is due to TSH receptor antibodies. Unfortunately, our eye cells also have, the cells in the eyes also have these TSH receptors. Therefore, these receptors can go to the eye and then cross-react in the eye muscles and adipose tissues, causing increased deposition of glucosaminoglycans and inflammation of eye muscles. Therefore, the eye socket will have a lot of pressure pushing the eye forwards, causing proptosis, and also exophthalmos. That is, you can see the sclerae lower down the limbus. That is exophthalmos. And exophthalmos and proptosis and this red angry looking eye are specific for Graves' disease. If you see these kind of patients, please do refer to endocrinology because we can treat this eye to become normal. Okay, now it's important for you to know about the natural history of Graves' disease because you need to tell the patient how long you are going to treat. Most of our patients are having Graves' disease. Therefore, it's important to know this. Now, Graves' disease, whether you treat or not, will go into a natural remission in majority after about 12 to 18 months, right? Whether you treat or not. But you can't allow this patient to wait for another 12 to 18 months without treatment. Therefore, right. Okay, I'll come to that later. Therefore, what we do is we get these TPO levels down to the normal level and maintain it until the natural remission occurs. At this point, we try to stop the medications and see whether the patient is in remission. Most of the patients, like let's say about 30% of the patients will remain euthyroid for the rest of their life. But 30 to 50% will relapse. So it's important to monitor these patients at least annually. And about 30% will become hypothyroid with time. Okay, therefore, what we have to do is you have to treat with carbimazole, and then when they come to normal levels, you have to reduce, make a dose titration or reduce the dose and maintain a very low dose until about 12 to 18 months. And only then we try to stop the medications and then see whether the patient has gone into remission. And then we monitor these patients periodically, minimally, at least annually. But within the first year, we monitor quite frequently to see any relapse or hypothyroidism. How do we manage medically? Now, the problem here is thyroid gland produces a lot of T4, and T4 will become T3 in the peripheries, and T3 will act on the tissues, causing problems, especially nervous system and cardiac problems. Therefore, management is of twofold: symptomatic treatment and blocking the thyroid hormone production. Symptomatic treatment is by blocking the periphery action of T3, right? So when we give propranolol, beta blockers, it will block the action of T3 on tissues, so as it will block T4, T3 conversion. And then also, it is not enough. We need to block the production of thyroxine by giving antithyroid drugs. The antithyroid drugs are carbimazole or PTU. Now, I told it's important to check the check the T4 levels. And why is it important? Because when you prescribe carbimazole, if somebody has a T4 level just above the upper limit, or if somebody has T4 level 3 times the upper limit, you should not prescribe the same dose to all the patients. Therefore, how much of carbimazole prescribed should be depending on the T4 levels. I've put it in this graph. So it depends on how much higher the T4 levels. The dose can vary from 10 milligrams a day to 60 milligrams a day. PTU is the same. Therefore, you need to know the T4 levels to start the treatment. Otherwise, you will be blindly starting treatment and you have no difference from other doctors. So be specific and you can stand out from others. Okay. Now, this is how I do. I start initially with beta blockers and carbimazole, and then monitor only with T4 in about 4 to 6 weeks, because TSH takes long time to recover. Therefore, I go mainly with T4 initially, and then when the T4 levels become normal, I try to stop beta blockers and reduce carbimazole dose. Otherwise, it will, if I don't stop, then you can see it will go in the same decline. It will make the patient hypothyroid. Therefore, what I do is I reduce the carbimazole, and then only once the T4 level is normal, only I do TSH and T4 both. Then I titrate the carbimazole dose to come to a very low dose and maintain it up to about 12 to 18 months, and then stop at that moment. And then in the initial 1 year, I monitor 3 monthly, and after that 6 monthly to annually, I monitor TSH T4 to see any recurrence or relapse. And if the patient gets hyperthyroidism again, you need to refer for definitive treatment. Okay, just a small example. I think I'm running out of time. I don't think I can cover all, but I'll try to see, because these are important and these are the mistakes that we do. Now, this patient, Graves' disease, first visit, okay, T4 is 54 and we have started 40 milligrams of carbimazole depending on the T4 level. Okay, now second visit, patient comes and TSH is 0.05, still suppressed. Then what the doctor does is, okay, TSH has not improved, so carbimazole dose will be increased to 45. Third visit, TSH is 0.2, okay, slight improvement, then we'll continue carbimazole 45. If you do like this, then very next visit, patient will be hypothyroid. And why is that? What have you missed? Here, if you see, had you done your T4 levels in this hyperthyroid patient, you see that T4 levels have come down, become normal in the second visit, although TSH takes long time to recover. Therefore, if you do the T4 levels, it has become normal. Now, this is the time for you to reduce the dose, not to increase. Because there's like I said, what I do, T4 has responded markedly, right? And now in this patient, you can see the T4 level has gone into a hypothyroid at this point. Had you done at least T4 in this point, you would have noticed T4 is going into hypothyroidism. Unless you reduce the dose, patient will become hypothyroid. So this is the mistake that we have done, not checking T4. How to do it correctly? Now here, 54, and you do T4 levels, it's 20. Then the ideal way should be to reduce the thyroxine dose by 50%. Well, I would make it 20 to 25. And then next time also, if the T4 level is further low, I would further reduce the thyroxine level, carbimazole level, irrespective of TSH levels. Then you will see by next visit, you will get a proper controlled hyperthyroidism. So that's what I do in my practice. Talking about PTU and carbimazole, we usually use carbimazole because it's more potent, and it is its duration of action is 12 to 24 hours. So I can even give daily dose rather than BD dose. But PTU has its own advantage, especially during first trimester of pregnancy. It's safer than carbimazole, and also it inhibits T4 to T3 conversion, especially in acute crisis situations. This is important. Even now, currently, I have a patient in Norelia who is having neutropenia. So agranulocytosis or neutropenia is a very problematic complication of carbimazole and PTU. You need to educate the patient whenever you write carbimazole regarding this. Luckily, my patient, I brought her down to the hospital for some other thing to see that the patient is having fever, to see that her neutrophil count was 0.6. Sorry, WBC count was 0.6, neutrophil count was 0.01. So it's terrible. So luckily now she's recovering. Agranulocytosis is very rare, but having had that, patients will die unless you treat. And cholestasis is a little bit of a problem in carbimazole. Some patients do get allergies. Allergy is not an indication to stop the medication. You can give some anti-allergic medications in addition to the treatment. Now, aplasia cutis in neonates can happen in carbimazole. That's why during the first trimester, we give PTU compared to carbimazole in pregnancy. Now, what is important as GP? When you prescribe these medications, give either written information or verbal information saying, stop these medications and see a doctor immediately if you have fever, sore throat, mouth ulcers, or sign of infection, or if you have yellow eyes and pale stools indicating cholestasis. You need to tell this to patients, otherwise patients don't know. And when they come with fever or something, do a full count and liver functions immediately and then attend to it. Stop the medications and refer to a specialized center if they have agranulocytosis immediately. Now, Graves' orbitopathy, I mentioned this. These are angry-looking, proptosed, jutted out eyes. So we classify them and we classify the severity, and there are treatment protocols using steroids, rituximab, radiation, and rehab surgery, and sight-threatening, like visual, if there are visual impairment, emergency surgeries are being done. So important thing is, if you see a patient with eye disease, please do refer immediately to specialized services. And if they have visual problems, immediately. Okay. I think I would skip this. Now, what can I do? I think I have run out of time. It's almost 10. You can suggest what I can do, the organizers. Until then, I will try to answer a few questions that I have.
Can you hear me, Sonali? Can you hear me?
What are the special indications to do free T4 and T3? So, hyperthyroidism, do T4. T3, you don't do. I very rarely do T3. I see a lot of reports with T3. I don't do T3 because T3 is done only in subclinical disease for confirmation, and very rarely, sometimes we do T3 in T3 tox. If I suspect T3 toxicosis in resistant thyrotoxicosis. Therefore, don't do T3. as a routine practice, but do T4 in hyperthyroid patients. Okay, let me see other, what is methimazole? Methimazole is equivalent to carbimazole, right? There's a small dose change, but methimazole is almost carbimazole. What will be the time period of visits? So usually TSH T4 takes time. I usually ask them to come in 6. Hypothyroidism, of course, I'm very lenient, 8 to 12 weeks. In hyperthyroidism, 6 weekly initially, after that 2 monthly with the T4 and TSH. How long we should treat hyperthyroid patients? I have seen treatment stopping after 1 month. So in high classic Graves' disease, we don't stop treatment until about at least 1 year. In toxic multinodal and solitary thyroid toxic nodule, you can't stop because patients will become hyperthyroid. You need to have a long-term medications or definitive treatment. Obviously, hyperthyroidism with thyroiditis, yes, you may stop treatment because you don't have to treat thyroiditis with carbimazole in the first place. Okay. So whether to do the rest. Well, okay. I'll try to cover thyroiditis because it's a huge area, the thyroid disease. If I do halfway, I don't feel comfortable doing a half lecture and giving knowledge halfway because then you are nowhere here or there. So if I do it, I will do incomplete. I'll just quickly try to do thyroiditis, and then you all can decide whether I should continue or not. Because PTU more than how do we choose between? So you don't have to choose between PTU or carbimazole. Choose carbimazole. If the patient is pregnant, first trimester, it's PTU. If the patient is in thyroid crisis, it's PTU. Otherwise, it's carbimazole. The other most important thing I forgot to tell. If somebody develops agranulocytosis or neutropenia with carbimazole, never ever change over to PTU because both have cross reactions. And if somebody gets neutropenia to carbimazole, they will definitely get for PTU. So in your practice, never ever change over to the drugs. That kind of patients need specialized management with sometimes plasmapheresis and immediate thyroidectomy. So please do refer to us. Okay, so I'll just go through scenario 4 because I don't think I can do quite lengthier because people will be sleeping over. So this is a 24-year-old female feeling unwell, coming with palpitations, sweating for very short duration, 1.5 months. Again, hyperthyroid symptoms. Diffuse goiter, on examination. You do a TSH suppressed, T4 high, urine HCG negative. Okay, this is hyperthyroidism, right? We discussed this. And somebody has started carbimazole for 2 months, and then patient becomes overtly hypothyroid. Why is this? Is it incorrect overtreatment or incorrect diagnosis? For T4 of 60, well, you may use carbimazole 15 TDS or even 20 BD. It should not be causing hypothyroidism in 2 months if it is Graves' disease. So my gut feeling would be, is this incorrect diagnosis? Why is that? Okay, now if you go to the history, this patient would tell there had been a neck pain before the onset of symptoms couple of weeks back. And then had somebody done the technetium scan, there would not be any uptake, whereas normal is like this. So this is a sick gland releasing thyroxine, already produced thyroxine hormone to the system. So this is thyroiditis. Now, this is the classic feature of classic history of subacute thyroiditis. Thyroid gland becomes inflamed. So gland becomes very leaky. Already produced hormones will be released into the system. Not the gland is producing, it's just leaking off thyroxine. then the patient becomes thyrotoxic because the T4 levels are high. Now, these T4 levels come down as now the gland is not producing, it just releases the already produced one. Once the levels are over, then they become normal, but the gland is still sick. Therefore, the amount of thyroxine which is in the gland is not enough to cope up with the body needs. As the gland is sick, patient becomes hypothyroid. And later, once the gland recovers, then the gland starts producing thyroxine and then becomes normal. This would take about 3 months to 1 year duration, the full recovery. But patient will have initial thyrotoxic phase leading up to 6 to 12 weeks and then followed by hypothyroidism. So in this thyrotoxic phase, as the gland is very much in pain, you will have high ESR CRP and will get thyrotoxic features. And in the second phase, ESR normalizes, gland starts production of thyroxine, but it's not enough. That's why the patient becomes hypothyroid and recovery occurs. But as this is inflammation, you do not treat with carbimazole, you treat it anti-inflammatory drugs. That's NSAIDs and steroids for this duration of time, followed by, if the patient goes into hypothyroidism, you check with TSH and T4, you start treatment with thyroxine for a shorter duration and then stop. I presume this kind of a diagnosis and treatment should be done at specialized centers, and but these patients come to the GPs. Therefore, it's important to identify these kind of features and refer them to the specialized services. Okay, and toxic, the hyperthyroidism can be due to nodular goiters, like I said, and when they are present and resistant or recurrent graves, the management is initial medical management followed by a definitive treatment, either radioactive iodine or surgery. Okay. I think I have covered hypothyroidism and hyperthyroidism. So, hypothyroid patients, dietary advice. There's a question. No, there are no special dietary advice for hypothyroid patients. Some ask, Gova, Ruba, Kavata, Kaman, the Kela. Their thyroid gland is already not working. Any drug or anything or food item can't make it work lesser than what it is in overt hypothyroidism. So there are no food restrictions in hypothyroid patients. But if there's a goiter, sometimes these Goa and Ruba like vegetables can have goitrogens and further reduce the activity of enzymes. So they may have some effect with goiter enlargement, but hypothyroidism per se has no restrictions. Okay. Right. What shall I do? Okay. To continue. Just give me 1 minute because I'm supposed to pick up my parents. They went out for a dinner. So I'll just call them, and if they are okay, I'm happy to continue. Just give me 1 minute, please. So, luckily, my parents are not finished yet, so I can continue. So if it's not a must for you all to stay, those who are not feeling lethargy or not hyperthyroid or not feeling sleepy, you can stay, and others like, I understand it's late. So I'll just, I would not actually go for pregnancy and nodular goiters. I'll just touch on subclinical thyroid disease and wind it off, because this is very, very important in GP practice. Most of these patients come to us also being referred by GPs, and I just say, okay, repeat this and come again. You don't have to do that. So you can do the initial part, and if it is needed only, can send to us for decision making. Okay. Now, there's one question in hyperthyroidism. Hyperthyroidism, can you manage at GP level? Well, you can, but if it is thyroiditis, I would recommend to refer at least once so that we can instruct as to what to do and to come to a diagnosis if you suspect. And Graves' disease carries a lot of comorbidities and problems, especially if there are eye disease. So Graves' disease with eye disease, please do refer to us. There are no other options. Graves' disease alone, if you are very much confident in managing, I don't mind you managing it, but not haphazardly. And if you refer to us, we can give a plan and send, or here and there. That I do with good GPs, if I'm confident. And it's all in Graves' disease, it's always good to get at least an opinion. Subclinical hyperthyroidism, it's better to get the diagnosis. And then nodular goiter, toxic nodules and solitary toxic nodules, you can manage at GP levels. But remember, long-term carbimazole is not an option for them. You have to go for a definitive treatment, either thyroidectomy or radioactive ID. Okay, so let's go for subclinical thyroid disease. This is what you get mostly, right? And this is what you have to deal with. Now, let's say a 67-year-old lady coming with past history of ischemic heart disease, and in routine evaluation, she's okay. She's otherwise normal. She comes with a TSH of 0.05 and no symptoms of hyperthyroidism at all. You just detect this. She's quite well, right? And then you do, now this I told you, in TSH very low levels, always do a T4. You do a T4 and that is normal. Okay, T4 is normal, but TSH is suppressed. What can cause this? Can this be due to T3 elevation, although T4 is normal? It is possible. We call that T3 toxicosis. So here, this is an indication for you to do a T3 level. Because you suspect T4 is normal, TSH is still suppressed. So there should be something else suppressing TSH. So is it T3? Then do a T3 level. This is very rarely an indication for T3. Now T3 is again normal. So all the hormones are normal, but TSH is suppressed. Okay. Similarly, a 35-year-old lady comes with lethargy. This is the commonest symptoms you get, I guess. Lethargy, sleepiness, weight gain, blah, blah, blah. So you do a TSH levels and it becomes 8, right? Now, when you have a TSH level less than 10, we always recommend you to do a T4 level. Less than 10 means TSH elevated, but not more than 10. Please do a T4 level. I admit I told you not to do a T4 level in hypothyroidism. Still, I stand on my ground. Don't do T4 levels in hypothyroidism. But if you have a marginally elevated TSH, less than 10, definitely do a T4. You don't have to do a T3 here, but do a T4. Now here, T4 is normal, but TSH is marginally elevated. Right? Now, all these are asymptomatic groups. The hormone panel is normal, but TSH is either suppressed or elevated marginally. This is called subclinical thyroid disease. Now, low TSH with normal free T3 or T4, we call it subclinical hyperthyroidism, and high TSH, that is like less than 10 still, with normal T4, you call it subclinical hypothyroidism, right? TSH is raised because of that hypothyroidism, but T4 is normal, therefore subclinical. Here TSH low because of that hyperthyroidism, but T4, T3 normal, therefore it's subclinical. If you do just one report of TSH, T4 and see this pattern, please don't send to us. Repeat the test in about 3 months, 2 to 3 months. Majority of them will become normal and you don't have to refer even. Don't start treatment. Please don't start. Just repeat the test in about 2 to 3 months' time. And then confirm this is subclinical disease. If it improves, you don't have to treat even or think of treatment. So protocol is you detect some kind of subclinical hyper or hypothyroidism, you repeat it in about 2 to 3 months' time and confirm the diagnosis. Then only you consider whether should I be treating this patient or not. Okay. Subclinical disease is defined as disease which is not severe enough to present with definitive or readily observable symptoms. They usually don't produce symptoms. It's just a biochemical diagnosis. Problem is treat or not to treat. Now, the problem we get is they just come with one report of TSH. Then we tell, okay, we don't have to treat now. And then repeat this test in about 2 to 3 months and come back. And they go with a very huge face. Me doctor nam pisu meya danne naha endocrinology wage phase එකකින් තමයි යන්නේ. So it's not the case. You don't have to treat unless you confirm the diagnosis. And if you see this now, this is subclinical hyperthyroid group. That is normal T4, T3 and then low TSH. And over to group, of course, you know that TSH, T4 TSH is low and T3, T4 are grossly elevated. So this is the group that I'm talking about. Normal T4, T3, TSH is suppressed. If you see over 5 years, 50% of these patients become euthyroid, right? They don't actually need treatment, but you can't wait for 5 years. But majority, what we in our clinical practice, if you repeat in about 2 to 3 months, some of those groups will become normal because it could be even due to sick euthyroid or some disease, a transient change in thyroid profile. Therefore, do repeat in about 2 to 3 months. Only the development of overt hyperthyroidism is 1 to 15% per year. So if you see 100 patients, only about 1 to 15 patients will go into overt hyperthyroidism. So it's very tiny amount. Then the question comes, treat or not. Why do we think of subclinical hyperthyroidism? In the group aged 65 or more, it is associated with atrial fibrillation and it is associated with osteoporosis. That is in elderly population. Therefore, we have a definite criteria to treat if the diagnosis is confirmed over 2 months, and it is this. If the TSH is suppressed, that is 0.1 or less, and age is more than 65, for the reason that I told, to prevent AF and osteoporosis, treat. So very suppressed TSH with age more than 65, treat. Suppressed TSH, even though age is less than 65, but if the patient has heart disease or osteoporosis or hyperthyroidism or postmenopausal, treat. Right? If they don't have a suppressed TSH like less than 0.1, you may not treat, you may observe. So you yourself don't have to take this decision. If you confirm a subclinical disease, especially subclinical hyperthyroidism, I would suggest you to make a proper referral to endocrine services so that we can give you the proper instructions as to treat or monitor. Okay, let's see this patient. 70-year-old lady with diabetes, routine evaluation TSH 0.05. T4, T3 normal repeatedly, so it is subclinical hyperthyroidism, no symptoms. She's 75, no other disease at all apart from diabetes. So she falls into a category TSH less than 0.05, which is less than 0.1, and she's 70, she's more than 65. In that group, irrespective whether she has AF or heart disease or osteoporosis, even she doesn't have any of those, it is recommended to treat to prevent AF and osteoporosis. Let's say 62-year-old lady coming with past history of ischemic heart disease. And routine evaluation, TSH is 0.05, T3 normal, which we repeated and confirmed. No signs of symptoms. What about this? Her TSH is less than 0.01, but she's less than 65. She's 62. Where does she fall? She's 62, but she has a ischemic heart disease. Then TSH is suppressed. It is recommended to treat. What about this lady? 49-year-old rheumatoid arthritis, TSH is 0.3, just marginally low, T3, T4 normal. What do we do? She's less than 65, asymptomatic, no heart disease or anything, and TSH is above 0.1. You may observe, you don't have to treat. So likewise, the decision differs. What about this subclinical hypothyroidism? This is the commonest entity I think you get. This is this group. TSH is slightly raised, but T4 is normal. If you take over 5 years, 60% become normal without treatment. Only 1 to 5% per over 5 years go into overt hypothyroidism, and the chances are more for TPO positivity. Therefore, treat or not to treat is a problem in this group. Let's see how we decide on them. Before telling you the criteria, okay, let me just scroll through the questions. There are loads of questions. Skin manifestations can observe in patients with thyroid disease. Well, skin manifestations, it's a vague thing, but there are no direct effects. Overt hypothyroidism can have dry skin and dry, scaly skin in overt hypothyroidism. And overt hyperthyroidism can have oily, sweaty skin. Subclinical disease usually do not present with skin disease. And some say eczema and this and that, but it is not directly related with thyroxine problems, especially subclinical disease. For patients with asthma, what is the drug that we can use? Yeah, propranolol cannot be used in patients with asthma. In that case, we can use diltiazem only to bring down the heart rate. It will not block the sympathetic activity. It's unfortunate we don't have any other drug, but diltiazem will be useful to bring down the heart rate of hyperthyroidism. Is there any probability of subclinical hyperthyroidism become hyperthyroid? Yeah, I think I told. How do you manage a patient who's taking thyroxine, following thyroidectomy, presenting with normal T4 and slightly elevated things? Okay, this is out of way, but okay, patient had a thyroidectomy and on thyroxine, and TSH is 7.5 and normal T4. The basic thing I told in my lecture, if the patient is on thyroxine, that is patient is hypothyroid, don't do T4. That's the basic thing, right? You get into all these kind of problems if you do T4 levels. It is misleading in patients who take thyroxine. So if this patient is on thyroxine, following thyroidectomy, you just do TSH alone. If TSH is high, make sure the patient is compliant or not. If the patient is not compliant, don't change the dose. Just make sure the patient becomes compliant next time and repeat the TSH. If you're sure the patient is compliant, which means that your dose is inadequate, change the dose and see. If the dose goes into very high levels, then refer to us. We will sort out any malabsorption problem. Okay. Now, imagine this person. Again, even yesterday I saw a couple of referrals with this, which need not to be referred to me. You can manage this, right? So this is a 70-year-old lady evaluated for sleepiness. TSH is 7.3 and T4 is normal. I told you, you need to do a T4 level in this case where the TSH is less than 10. Treat or not is a problem. Well, the GP has written as thyroxine 50, and actually, luckily, he had cut it and asked to meet me. Okay, patient came like this, similar patient, and TSH was 7. I reassured and sent home. right? Why is that? If you see, now this is a 70-year-old lady. Now with age, TSH increases, and that is a normal phenomenon. For somebody of age 80, even a TSH of 8, 10 would be normal. So somewhere around 7, 8 is pretty normal for somebody with the age of 80, right? So you can see the TSH range increases with age. So for young in blue, it is the normal range we see in reports. Middle age up to 60, it's again, the range goes up to 4.75. And for elderly population, especially 70, 80, for a lady of 70, 6, 7 of TSH is normal. Therefore, if you treat, you are doing more harm. Therefore, this lady should not be treated and reassured saying this is appropriate for your age and sent home. Okay, but that is with the age. But subclinical hypothyroidism, the management is if the age is less than 70 and the TSH is, if the TSH is more than 10, we always treat. That's why I told if the TSH is less than 10, you always have to do a T4 level. TSH more than 10, treat with thyroxine. But be cautious of patients above 70. You may not need to treat even. You can assess with the comorbidities. If the TSH is below 10, 4 to 10, then there are very specific indications for you to treat if the subclinical disease is confirmed. That is, if there are symptoms of hypothyroidism, don't treat for lifelong. Just give for 6 months and then see whether the symptoms improve. If they don't see any improvement, just stop the thyroxine. If they have a goiter, you may treat. If they are TPO positive, you may treat. Or if they're planning for a pregnancy or if they are subfertile, you may treat. Now, this is one indication where I do TPO levels. If the TSH falls into subclinical group, then do a TPO level. If they are positive, you can jolly well rationalize yourself to treat these patients. And the aim is, target is normal TSH levels. Okay, now let's go for few examples. Just give me 1 second. Okay, so 35-year-old lady, evaluated for lethargy, the same lady. No symptoms of hypothyroidism. Obviously, if you ask lethargy and weight gain and little things, they might say that weight gain is not due to TSH, it is due to overeating, right? And no goiter, and the family is completed. She's not planning for a pregnancy or she's not subfertile. In that case, of these criteria, TSH is less than 10. And she does not have symptoms, no goiter, and then what do we do? Right? If you can do TPO levels, but she has completed her family also. In that case, it's not really needed to treat. You can monitor TSH and then wait. If it becomes more than 10, you can treat. What about this lady? 28-year-old, TSH is 6.5. No other symptoms, no goiter, but she's subfertile. In that case, you don't even have to wait. You can start thyroxine and the target would be TSH less than 2.5 for subfertility. Here, the dose would be a very low dose because TSH is 6.5. Here, you don't go with the weight adjusted dose. You may start with 25 or 50 and then adjust according to the TSH levels. Okay. Summary of subclinical thyroid disease. Subclinical hypothyroidism is raised TSH with normal T4. Hyper is low TSH with normal T4, T3 both. You can't confirm this diagnosis without confirming it again in about 2 to 3 months. If you do it only, then this diagnosis is confirmed. Majority of these patients, if you repeat these tests in 2 to 3 months, they become normal. In that case, you don't have to treat. Treatment is dependent on few criteria. In hypothyroidism, TSH more than 10, you treat. If it is in between, if the patient has TPO antibody positivity or planning pregnancy, subfertile, or if there are symptoms of goiter, you may treat. Especially if there are symptoms, if you suspect, only give for 6 months and then see the improvement. In hyperthyroidism, age 65 or above, treat irrespective of symptoms or not. Age less than 65, you treat only if these criteria are met. Cardiac disease, osteoporosis, menopause in the background of less than 0.1 TSH. So, do not treat the first report. Always repeat the test and confirm the diagnosis in about 2 to 3 months. So, subclinical hypothyroidism, consequences are more in young, like in subfertile and pregnant ladies. Subclinical hyperthyroidism, consequences are more in elderly, as for osteoporosis and AF. Therefore, treatment decision depends on age, symptoms, TPO antibodies, fertility vision, comorbidities. So this, well, some patients may tell, okay, what my doctor understand is black, but no, we know what we know. We know our theory and we know the evidence. Therefore, we can, with confidence, we can tell these patients. I think I will wind up with that because those are the common things that you come across. Thyroid disease in pregnancy should be managed in specialized centers. Detect and please do refer. I guess it's okay. There are some questions. I'll try to answer the questions. Prescribing thyroxine dose alternatively, like 75 one day and 100 following day. Well, sometimes we do, even I do. I go for very odd regimes with a reason, because thyroxine has a long half-life of 7 days. And sometimes if you can manage with a very reasonable number like 100 or 50, that's good, because it's easy for the patients. Now, if you prescribe me thyroxine as 75 one day and 100 the other day, I sometimes forget. I might think, okay, what did I take yesterday or what did I take today? I forget. So try to make it very convenient for the patient. Sometimes I give, okay, weekdays you take 100, weekends you take 75, or weekdays you take 100 and weekdays you take 50. So something like that, to come to an in-between dose. So try to be convenient for the patient, make it convenient for the patient as well. Can a patient with thyroid disorder present with chronic urticaria? Well, there are some case reports saying chronic urticaria is related, associated, but it's not causative. So thyroid problems can't cause chronic urticaria, neither chronic urticaria can't cause thyroid problems. There may be associations, especially autoimmune disease can coexist. So there could be an association, but there are no criteria as to say chronic urticaria should be treated with thyroxine. So maximum dose of thyroxine, there are no maximum doses of thyroxine. If you exceed the required dose, if you exceed 2 micrograms per kg per day, it means that your thyroxine is not being absorbed or patient is not compliant. Patient is taking tea or food with the thyroxine and it is not being absorbed. So there's no maximum dose, but higher the dose, if the patient takes it correctly, there can be some cardiac issues. So you have to make sure the patient has no cardiac issues.
Sonali, can you hear me now?
What is recommended guideline to go through for further reading? Well, guideline-wise, so my lecture is based on ATA guidelines and European guidelines and my experience and the teachings I had from my senior endocrinologists here local as well as abroad. And recommended guidelines are ATA guidelines, American Thyroid Association guidelines. I'm sorry, I could not cover all the things. The other things are pregnancy related and also just goiters. Goiter, of course, I'll just tell you need to do a scan in any large goiter, and scan findings will suggest whether you need to do a FNA or not. That's quite a big decision, because nowadays we see a lot of people putting needles in, even in tiny lesions, which you don't have to. Nowadays, we don't put needles in less than 1 centimeter lesions. It has to be 1 or 1.5 centimeters or more to put a needle in even. And depends on the histology, we decide whether to go for thyroidectomy or watch and wait. And thank you very much for the opportunity. And I wish you all the very best. And we believe in a good GP practice and good GP system. And the use of this lecture is for you to not to refer all the patients, but identify the relevant patients and refer to the specialized services where appropriate, when you are not quite confident or when you think it is needed. But simple hypothyroidism, subclinical disease, it's in your territory to manage. It's not the specialist teams who should be managing these patients. It's the ground level GP systems who should be managing. Thank you very much.